Good day, everyone. I am Dr. Shannon Trecartin, a professor in the School of Social Work at Andrews University and a research scientist at the Institute for the Prevention of Addictions. Just really quickly, I want to give a disclaimer that our graphs and our PowerPoint design were AI aided using Claude, yet our analysis was conducted by us using SPSS.
And Alina Baltazar, also professor of social work at Loma Nazarene University in San Diego. I'm also a research scientist at the Institute for Prevention of Addictions, but also a licensed clinical social worker and a psychotherapist. In fact, I actually have to see a client right after this. Now, we want to thank AHSRA for the support of this research. We could not have done it without them. So to better understand the results we're going to be sharing with you, it's good to understand global rates of depression. According to the World Health Organization, rates are probably underreported due to the nature of the data and how it was collected. But it's important to note that women do have a 1.5 higher times likelihood of having depression compared to men. Actually, in the US, women are twice as likely to be diagnosed with depression. Now, there are multiple theories why. The rate differences actually start at puberty, so there's something about the experience of menstruation, childbirth, and menopause, things that men don't experience, that increase the chance of depression. But there also are unique stressors that women experience, though some involve some cultural context. Being a single parent, workload, differences where women are often working outside the home and still taking care of the home responsibilities, and higher rates of eating disorder and anxiety. But there are definitely cultural variations with those first three. But globally, women are more likely to experience poverty and have higher rates of sexual abuse, which are all strongly linked to depression. So when considering these global rates of depression compared to the rates found in our study, we want to point out that depression questions used in the study are a screening tool, not a test to verify a clinical diagnosis in ways that the WHO tried to do. So the SDA Church is a global church where members live within a cultural context. So this includes social, economic, conflict, and healthcare challenges, which is important for local pastors to better understand so they can meet the needs of their local congregation, but also for regional church leaders can work on developing programs to better support these local pastors. Now, the SDA health message, as we know, is very intentional in addressing and improving physical health, which has been related to longer lifespan, but we don't really understand the mental health patterns as well. So this global study is a unique opportunity to explore cultural differences and patterns, and in addition to explore how cultural context might have an impact on depression level gender differences. So the purpose is to identify global patterns of possible depression, but important to also keep in mind there is a cultural context that could influence the interpretation of the questions and the experience of the described symptoms. So for this study, there are two main areas we focused on. What is the prevalence of probable depression in the global church, and what is the difference within divisions and attached regions? And then oh yeah, go ahead.
Go ahead. We also focused on gender patterns. So, what are the differences in the global church? And then also, what are the differences in the divisions and attached regions?
So I just want to point out where this data was collected. It is the 2022-2023 Global Church Member Survey. So this is the entire Seventh-day Adventist Church members being surveyed. So it led to a usable surveys of 150,000. So those of you who are researchers, this is actually really wonderful to be able to look at this many respondents. And so we were able to put together a global meta file. I also want to point out this included the 13 divisions and even 2 regions that aren't fully identified as divisions. And there were slightly more men that had usable results. And Shannon, Dr. Trecartin will explain how these results were calculated.
Okay. So, for those of you who are interested in the abbreviations, the regions were the Chinese Union Mission as well as the Ukrainian Union Conference. The weighted global sample, as you see, shows that there were more men than women participating in the survey. So this is a quantitative survey design, and research teams across the world, across the divisions in the World Church, they collected data using primarily stratified cluster sampling approaches. And those data were cleaned and compiled into a global meta file. We're using that global file. The weighted results were used for simply producing our global survey estimates, because the weights were calculated at the division level. And all division results that you're going to see today are unweighted. Because the sampling and cultural context differs across divisions, we're careful not to interpret the division level results as simply a ranking of one region against the other. So as we move forward, just remember we're not trying to compare divisions to each other.
So the PHQ-2 is a significantly shortened version of a longer depression screening instrument. Though this tool is still considered reliable and valid scale, it focuses on symptoms that are most associated with depression. And Dr. Trecartin will explain the analysis of the results for this study.
So this was a pretty straightforward approach, really using SPSS for the analysis. And as was mentioned just previously, the global estimates are weighted based on division membership size because some divisions participated more than other divisions in the survey. We're going to present percentage estimates of respondents who scored a 3 or higher on the PHQ-2. And Dr. Baltazar will describe that in a moment. And then we'll present the percentage point difference for each division based on gender. Because this was a global survey, an important question is whether or not the PHQ-2 is appropriate across different languages and national settings. The PHQ-2 is useful partially because it's brief, right? It contains only 2 items. It's also been translated and studied across multiple languages and populations. And the evidence shown here on the left describes research involving Latvian, Russian-speaking primary care patients, rural older adults in China, people living with HIV in Pakistan. We have Spanish-speaking immigrants in Chile and an Arabic-speaking caregiver sample. So collectively, these studies support the PHQ-2 as being useful as a brief screener across diverse settings. But again, cross-cultural use does not mean that every score has exactly the same meaning in every area. Dr. Baltazar?
So the PHQ normally contains 9 self-reported questions, which is used by healthcare providers to screen for, diagnose, and measure the severity of depression. So the PHQ-2 includes the first 2 questions from the 9-question scale. So the participants were asked to rate how often they have been bothered by the following problems over the last 2 weeks. Little interest or pleasure in doing things, and then the second question was feeling down, depressed, and helpless. So the scoring was a 4-point scale. So not at all was scored as a 0. Several days in the last 2 weeks was a 1. More than half the days was a 2, and then nearly every day was a 3. So the total score range is from 0 to 6. The recommended score that indicates need for further testing is a 3 or higher. And so those are the results you're going to see, those who scored 3 or higher. So this is those who scored that. Now, slightly more women had concerning levels of depression symptoms that warranted further testing. Now, these rates seem high, but not really comparable to the WHO rates of 5.7%. Though there is a difference between men and women, it is not considered statistically significant.
Okay, so this slide displays the percentage of respondents who screened above that criterion of 3 or higher within each division or attached region. I want you to be aware that the order has no meaning here. The choice is intentional. I mean, there's a little bit of organization in terms of where in the globe things are, but they're not lined up based on which division is higher or which region is higher. This is simply showing us the proportion or the percentage of respondents in that division that scored at least a 3 or higher. So it's not a league table where we're comparing. These percentages, they're really most useful as local screening estimates. So each division team, these, by the way, for those of you who aren't familiar with what this is, these are the 13 divisions of the World Church and their abbreviations. And during the Q&A time, if there's something that stands out to you, we can talk about specific areas. But each division can use this kind of as a starting point for asking further questions about the mental health needs, available resources, and just additional support that might be needed. Remember, the global estimate for the World Church was 22.1%. So that's helpful to know as well. Now, this slide, this is focusing on the within division gender differences. This chart is showing the percentage point difference between women and men. And positive scores mean that women are screening higher, and negative scores are saying that men are scoring higher. Globally, women score about 1 percentage point higher than men. That was true for the World Health Organization study as well as for our study. It's just they're different ways of comparing, or different instruments, really. So women had statistically significantly higher positive screening rates in the Southern Asian Pacific Division, in the South Pacific Division. That's here, Southern Asia Pacific, South Pacific. I don't know that you can see my pointer right now. That's okay. Here where it's yellow. Also in the Inter-American Division, South American Division, East Central Africa Division, Southern Africa, India Ocean Division. The largest observable gaps are in the South Asia Pacific Division. They're at the top, and in the where women were screening 7.1 percentage points higher, and then the South Pacific Division was 5.5 percentage points higher. In the Chinese Union Mission, that's CHUM right at the very bottom, and in the South Africa India Ocean Division, men screened somewhat higher, but there was not a statistically significant difference at the 0.05 level between those. So, and then in the Trans-European Division, we didn't see a difference between women and men. So these data simply identify a pattern. They do not by themselves explain the cause of why this may be occurring in each division. So we have several recommendations. First, we want to recommend, and I know that we are doing this, retaining the PHQ-2 for future Global Church member survey waves. Using this same measure is going to allow us over time to start to allow the divisions to see how these scores may be changing or not changing in the future. And it helps monitor what's happening, right? Secondly, future analyses can examine how the PHQ-2 results interact with other Global Church member survey variables. Help-seeking variables, for example, or religiosity or social support, to see if there's any sort of a interaction or mediation or any explanation that comes from how those variables are functioning together or not. And then third, division teams should review their findings with local mental health professionals and researchers and ministry leaders to know what's happening at the ground level. Dr. Baltazar.
And now I'm going to talk about that practical response of that mental health clinician. So as noted, there are quite a bit of cultural differences as it relates to gender differences in relation to concerning depression symptoms. So it's recommended each division develop a culturally appropriate response to address this problematic health issue and how it impacts women. So as mental health professionals, we encourage pastors to normalize the benefits of screening. So experiencing depression is not a moral feeling. We can just address the stigma, that would be huge. And I know a lot of us who are mental health professionals are really trying to do this. And pastors are trained to support those who are struggling emotionally and have unique strengths in being able to address any underlying spiritual struggles or to build on a person's spiritual resiliency, but they are not trained to diagnose or treat depressive disorder. So they need to know where to refer someone for professional help if needed.
So these are selected references in supporting this study. We want to thank you so much for your attention. We hope these findings are encouraging and encourage you to conduct more research thoughtfully, and also make sure that it's locally informed, and consider the cultural context of which your findings apply. Thank you.